A very good morning to all students and welcome to the class on macrolide antibiotics. So by the end of this class, you should be able to list the different examples of this group. You should be able to describe the mechanism of action, the antimicrobial spectrum, important pharmacokinetic considerations, adverse drug reactions, and indications for use of the different members included under this class. We all know these class of antibiotics are a very popularly used class of drugs, and you would have come across this class of drugs in the wards as well as would have used these antibiotics at some point of your life. Now, why are these called as the macrolides? This is because they have got a macrocyclic lactone ring attached to their sugars. Macrocyclic lactone ring attached to sugars in their chemical structure. Let us look at the different examples included under this group. So the first example is erythromycin, and this was the first drug discovered under this class from a natural source, a bacteria called Streptomyces erythraeus in 1952. This drug is also the prototype drug of this class. Hence, we are going to discuss every aspect of erythromycin and then we'll compare the other drugs with erythromycin. The other drugs that are included under this class are the semi-synthetic macrolides, otherwise called as the newer macrolides, because they were discovered much later than erythromycin. Now, I have derived a mnemonic for remembering the examples of the semi-synthetic or the newer macrolides. The mnemonic is cards of semi-synthetic newer macrolides. That is cards, you can remember the mnemonic cards. C for clarithromycin, azithromycin, roxithromycin, telithromycin, and spiramycin. So for your exams, you can remember the semi-synthetic newer macrolides as the cards of newer macrolides. Now let us look at the mechanism of action. So all these drugs are bacteriostatic at low concentration and become bactericidal at high concentration. So that is only for a few bacteria. So you have to importantly remember that they are bacteriostatic in nature. Now, what is their actual mechanism of action? All these drugs, they inhibit the bacterial protein synthesis. The bacterial protein synthesis. So, you would have come across different antibiotics which inhibit the bacterial cell wall, which have an action on the bacterial cell membrane, etc. For this group of drugs, they inhibit the bacterial protein synthesis. Now we have to see at which step of bacterial protein synthesis do these drugs act. Elongation and the translocation process. The translocation process. Now where do these macrolides act? They act mainly on the translocation step of the bacterial protein synthesis. Macrolides bind to the 50S ribosomes and inhibit the translocation of the elongated peptide chain from the A site to the P site. And the ribosome doesn't move along the mRNA to expose the next codon. Hence, the peptide synthesis is prematurely terminated. So I'll repeat that once again. Macrolides bind to the 50S ribosomes and inhibit the translocation of elongated peptide chain from A site to P site, and the ribosome doesn't move along the mRNA to expose the next codon. Peptide synthesis is thus prematurely terminated. Now let us look at the antimicrobial spectrum. So you can see on the screen that it is a narrow spectrum group of antibiotics. So it is mainly active against the gram-positive bacteria. However, it can also act on a few gram-negative bacteria also. But its important spectrum includes mainly the gram-positive bacteria. We will divide Streptococcus pneumonia, Clostridium tetani, Clostridium diphtheria, Listeria, and you have got gram-negative organism, that is Neisseria gonorrhea. You have examples of two spirochetes, that is Treponema pallidum, Leptospira. The next one is the additional spectrum of macrolides. That is, it is exclusively present for macrolides. Under this, you have got Mycoplasma, Bacillus pertussis, Haemophilus ducrei, Campylobacter, Legionella, Chlamydia trachomatis. There are other bacteria also which are included under the additional spectrum, that is Bacillus catarrhalis, Gardnerella vaginalis, Haemophilus influenza, Neisseria meningitis, Rickettsia. However, you have to remember the six first bacteria as an important members of the additional spectrum. I'll repeat again: Mycoplasma, B. pertussis, Haemophilus ducrei, Campylobacter, Legionella, Chlamydia, trachomatis. So remember the spectrum of macrolides in two parts, that is one which is similar to penicillin G. Examples: Streptococcus pyogenes, Streptococcus pneumonia, Clostridium tetani, Clostridium diphtheria, Listeria, gram-negative bacteria, Neisseria gonorrhea, then spirochetes like Treponema pallidum, Leptospira, and the additional spectrum Mycoplasma, B. pertussis, Haemophilus ducrei, Campylobacter, Legionella, Chlamydia, trachomatis. Now let us look how into the resistance to macrolides. So antibiotic resistance, as you all know, is an important problem that is faced by all. So certain bacteria have developed resistance to macrolides. Now how have these bacteria developed resistance to macrolides? The one mechanism is by the efflux mechanisms that the bacteria have developed to pump out the macrolides. The next one is the production of esterases enzymes by bacteria which hydrolyze the macrolides and do not allow them to act against the bacteria. The third one is the alteration of the target molecule, that is the ribosomal binding site for the macrolide in the bacteria undergoes an alteration, because of which the macrolide cannot bind to the site. So, by these mechanisms, some bacteria have developed resistance to macrolides. The important aspect of the resistance seen in macrolides is that there can be a cross resistance among different macrolides. That means if a bacteria is resistant to erythromycin, the bacteria will be resistant to the other macrolides as well, and it can be resistant to members outside the macrolide group like clindamycin and chloramphenicol. Now let us look at the important aspects of pharmacokinetics of erythromycin. So it is absorbed from the upper small intestine. The erythromycin base is acid label, hence we have to give it in the form of enteric coated tablets, which in order to escape the digestion by the gastric juices. However, now the erythromycin esters are available, which are acid stable and hence are better absorbed. The food retards absorption of erythromycin by delaying the gastric emptying. So hence you have to keep a gap between the food time and the drug in order to allow better absorption of the drug. This drug has got a wide distribution. It enters the tissues, abscess, serous cavities, prostate, and can even cross the placenta. However, it doesn't cross the blood-brain barrier. Now let us look at the metabolism and the excretion of this drug. So it is only partly metabolized in the liver. It is excreted in the bile in the active form. So the major part of the drug is excreted in the active form in the bile. So we do not require any dose reduction in a patient who has a kidney disease. You can see the plasma T half of this drug. It is very short at 1.5 to roughly 2 hours. Now let us look at the different preparations of erythromycin. So it is available as an erythromycin base which is acid labile and hence has a relatively moderate oral absorption. The esters available are erythromycin stearate, erythromycin estolate, erythromycin ethyl succinate. These esters are acid stable and are hence better absorbed than the erythromycin base. The dose of erythromycin is 250 to 500 milligrams 6 hourly and the dose is 30 to 60 milligram per kilogram per day in children. So this has to be given 4 times a day in an individual. It is available in the forms of tablets, syrups, suspensions and drops. For topical application, it is available as ointments. Let us move on to the adverse drug reactions of erythromycin. Erythromycin as such is relatively a safe drug. However, the most notorious adverse effects that are seen with erythromycin are the gastrointestinal disturbances like epigastric pain, nausea, anorexia, and diarrhea. Diarrhea is mostly seen in children using erythromycin and it is believed to be because of the action of erythromycin on the motilin receptors in the gut. It can also cause reversible hearing impairment at high doses. Hypersensitivity reactions are very rare with erythromycin. It can be seen with the estolate ester and is not seen with the erythromycin base or the other esters. Hepatitis has been reported with the estolate ester, especially in pregnant women. However, this form of hepatitis resolves on discontinuation of the estolate ester and it is also not seen with the other preparations of erythromycin. For this reason, the estolate ester has been banned in most countries. Now let us look at an important aspect of erythromycin, that is the drug interactions of erythromycin. So erythromycin is a microsomal enzyme inhibitor. Microsomal enzyme inhibitor. Hence, it can inhibit the metabolism of drugs like theophylline, warfarin, terfenadine, astamizole, cisapride, and so on. It can increase the levels of these drugs and lead to their toxicity. For example, erythromycin, if it inhibits the metabolism of terfenadine, astamizole, cisapride, the toxicity can lead to QT prolongation or torsades de pointes, which can be fatal. Hence, you have to be very careful when you prescribe erythromycin with such drugs. However, these drugs have been taken off from the market because of this fatal toxicity. Have a reference again to the spectrum: Mycoplasma pneumonia, whooping cough, chancroid, Campylobacter enteritis, Legionella pneumonia, and trachoma. Moving on to the newer macrolides. So remember the mnemonic cards: clarithromycin, azithromycin, roxithromycin, telithromycin, spiramycin. Now, what are the advantages of newer macrolides over the erythromycin? So, the newer macrolides, they have an expanded spectrum as compared to the narrow spectrum of erythromycin. They are more gastric stable as compared to the erythromycin. They also have a higher oral bioavailability, a longer T half, and they are more gastric friendly as compared to that of erythromycin. So in all of these newer macrolides, we are going to see these advantages over erythromycin. So we will start with our first newer macrolide, that is clarithromycin. So it is an O-methyl derivative of erythromycin. It has got an additional spectrum: Mycobacterium avium complex, Mycobacterium leprae, H. pylori. So it has got the same spectrum as that of erythromycin, but other than that, it has also got an additional spectrum: Mycobacterium avium complex, Mycobacterium leprae, and H. pylori. The important considerations in pharmacokinetics of clarithromycin are that it is acid stable, hence it has good oral absorption. It also has got greater tissue distribution as compared to that of erythromycin. Now look at the metabolism of clarithromycin. It is metabolized by saturation kinetics. That is, with increase in the dose, the T half of the clarithromycin increases from 4 to 6 hours to 6 to 9 hours. Even its excretion is a slightly different from erythromycin. It is excreted both by the renal and the biliary routes. However, it doesn't require any dose change in case of both renal and liver diseases. It is relatively a very safe drug. However, can occasionally see an adverse effect, that is pseudomembranous enterocolitis. So remember, clarithromycin can cause this pseudomembranous enterocolitis, and very rarely it may come across rhabdomyolysis also. The drug interactions of clarithromycin are very similar to that of erythromycin. It is also an microsomal enzyme inhibitor just like erythromycin, and the same caution has to be exhibited in its use also. Its safety in pregnancy and lactation has not been advocated. Now, what are the indications for use of clarithromycin? Just like erythromycin, it can be used in upper respiratory tract infection, lower respiratory tract infection, whooping cough, sinusitis, atypical pneumonia due to mycoplasma, staphylococcus induced skin infections, and so on, just like erythromycin. The additional uses include the Mycobacterium avium complex infection, which is seen in the AIDS patients, H. pylori infections as a part of the different triple regimen and the quadruple regimens that are advocated. In leprosy, it is used as a second line drug, and it has been used as a second line drug for other atypical mycobacterial infections as well. Moving on to the next drug, azithromycin, which is a very popularly used drug, and hence it is very important from your examination point of view as well as from your clinical practice also. Now, azithromycin is an azolide congener of erythromycin, and it has got the advantages of having an expanded spectrum, improved pharmacokinetics, better tolerability than erythromycin. It doesn't have any significant adverse drug reactions or it doesn't have any significant drug interactions or any significant adverse drug reactions. Other than the spectrum of erythromycin, it has got a high activity as compared to erythromycin. The activity against these organisms, which I'm going to mention, is higher for azithromycin as compared to erythromycin. Mycoplasma, H. influenza, Legionella, Chlamydia, Campylobacter, Moraxella, Mycobacterium avium complex, Neisseria gonorrhea. So these organisms you have seen as a part of the spectrum of erythromycin also. However, the activity of azithromycin against these microbes is higher than that of erythromycin. The one thing that you have to remember is that azithromycin is not active against the erythromycin resistant bacteria. Now, the important aspects of azithromycin, it is acid stable, hence it has got a good oral absorption, and the absorption is better from an empty stomach because food retards the absorption just like erythromycin. So it has to be given either 1 hour before food or 2 hours after taking food. It has got a higher tissue distribution and has a good intracellular penetration as compared to that of erythromycin. Its excretion is principally through the bile. And look at the T-half. It has got a long T-half, that is 50 hours. Hence, we have to administer it only once a day, and it thus ensures a good patient compliance. The dose of azithromycin is 500 milligram once daily dosing in adults. It doesn't have any significant drug interactions and not much adverse effects is seen with the use of this drug. The indications for use include all the uses we saw under erythromycin. Other than that, it is preferred as the first choice drug in Legionnaires pneumonia, Chlamydia trachomatis, Chlamydia pneumonia, LGV, donovenosis, chancroid, and PPNG urethritis. So this is very important drug as a first choice drug in sexually transmitted diseases like LGV, donovenosis, chancroid, PPNG, urethritis. So when you are mentioning the indications of azithromycin, you have to be specifically mentioning the various examples of STD where it is the first choice drug. And in case of chancroid and PPNG, the advantage is that it has to be given only as a single 1 gram dose. Moving on to the next newer macrolide, that is roxithromycin. It has got a similar spectrum and efficacy as erythromycin but has got a fewer advantages. That is, it is acid stable just like the other newer macrolides and has got better oral absorption. It has got a longer T-half, about 12 hours, so we have to administer it twice daily. It has also got better gastric tolerability. It is usually used as an alternative to erythromycin for better patient compliance. The next drug is erythromycin. It is a ketolide congener of erythromycin, has got a similar spectrum to erythromycin, but the notable thing is that it can act against erythromycin and penicillin resistant streptococcus pneumonia. That is the important thing. It can act even against the erythromycin resistant streptococcus pneumonia cases. So drug interactions are similar to erythromycin and there is a serious hepatitis risk. So because of these, the last 2 points, that is the drug interactions and the serious hepatitis risk associated with erythromycin, it is a reserved drug for pneumonia, sinusitis, bronchitis caused by erythromycin and penicillin resistant streptococci pneumonia. So this is only a reserved drug for resistant bacteria. The last one is spiramycin. This drug is not much in use except for preventing transplacental transmission of toxoplasma infection. So with that, we come to the end of this session. The important questions that you can revise from this chapter for your examination purpose is erythromycin. All the aspects of this drug are important. The newer macrolides, you have to pay special attention to clarithromycin and azithromycin, the drug interaction of erythromycin, and do not forget to revise the steps of bacterial protein synthesis and the different drugs which inhibit the different steps of bacterial protein synthesis. Thank you all for the patient hearing. Stay home, stay safe, stay calm. Thank you.